Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Jazz Pharmaceuticals, Inc.
Welcome to this Medscape Oncology program. I'm Dr. Misty Shields, Assistant Professor at Indiana University School of Medicine and Indiana University Simon Comprehensive Cancer Center here in Indianapolis, Indiana. Welcome to this program titled Case by Case, Managing Small Cell Lung Cancer through Real World through the Patient Partnership. Our program features 3 chapters, each focusing on a different case of a patient with small cell lung cancer. We'll use these cases to discuss optimal treatment of patients from diagnosis to therapeutic options and management. Our first case today is focused on navigating a new diagnosis of small cell lung cancer. Joining me today to discuss our first case are Dr. Roy Herbst, Professor of Medicine and Chief of Medical Oncology and Hematology at Yale School of Medicine. He is the Deputy Director of the Yale Cancer Center at Yale University in New Haven, Connecticut. Welcome, Dr. Herbst.
Thanks. Great to be here.
Next, I have Dr. Matt Rice, who is the Manager of Precision Medicine and Navigation for GO2 for lung cancer in Cohoes, New York. Welcome, Dr. Rice.
Happy to be here. Thank you.
So let's get into our first case. This is a lovely 65-year-old female who has comorbidities for Parkinson's disease, which she is not on treatment for, and type 2 diabetes. She was undergoing active evaluation for an abnormal mammogram and a breast biopsy that found DCIS, or an early stage of breast cancer. She was found to have a new right lung mass on additional imaging that prompted the CT scan you see here. She has an ECOG performance status of 1 related to her Parkinson's disease and otherwise is asymptomatic. Roy, what would you do for a patient who comes in with a new lung mass as a medical oncologist seeing patients with lung cancer each week? What would be your next steps?
Probably wouldn't change my next step, but I wonder, was this patient a smoker?
She was. She had quit over 10 years ago. She was not actively enrolled in a lung cancer screening program. That would have been ideal if she had been for evaluation of any lung nodules that might be concerning for lung cancer.
Well, I think that this patient certainly needs a biopsy of that mass. There are other concerning problems that you mentioned in the introduction, the breast and elsewhere, that I'd probably want to get some sort of biopsy, probably a core biopsy of that mass. Also complete the staging, with a PET scan, of the entire body. But a biopsy, I think, is the next step.
Matt, what would you offer this patient who is found to have a new lung mass? What would be your recommendation for this patient?
I think the greatest thing that a lot of patients struggle with at the time of diagnosis is just that it's an entirely new language they basically have to learn when it comes to the disease and what to expect from it. So the best thing that I usually find for individuals like this is to try to find a community they can kind of connect with.
You're absolutely right, and that patients deserve to have a community surrounding them and supporting them. As mentioned, the patient did undergo a completion of her staging with here a CT scan of the abdomen pelvis that was not performed and a PET CT, as well as an MRI brain. The patient had hypodensities in the liver that were FTG avid on the follow-up PET CT, as well as the area in the right lung and the mediastinum. MRI brain was fortunately negative. This patient underwent image-guided biopsy of the liver lesion that was consistent with small cell lung cancer.
Yeah, this makes sense. Seeing that there's liver disease, might as well biopsy a metastatic site and establish the metastatic diagnosis. So it looks like a very, very expedited workup.
Yes, I agree. If we can use the opportunity with the biopsy to both clinically and pathologically stage a patient, that's really the most efficient way. So, Roy, here, would there be an urgency for diagnosis of a new lung mass or liver mass here, especially knowing it's small cell? Is that the same cadence as other concerning areas, or is there any urgency to a diagnosis of small cell?
I would say yes. Small cells only about 10-15% of the lung cancers, but they tend to grow much more quickly and become symptomatic, more quickly. So yes, I think, you want to move quickly. It's not an emergency, but it is an urgency. You want to get the biopsy now that we know it's small cell. I think I'd want to see treatment initiated, rapidly within 2 or 3 weeks, max. And, we have to be careful. There's some comorbidities here we'll have to discuss, especially as we think about using immunotherapy and so forth. But no, I think this patient needs to be treated right away.
Absolutely. And would you, in your practice, do you ever encounter any potential barriers to getting patients in quickly for timely treatment?
Well, here we've already done the staging, the MRI of the brain. We have the PET CT. We're pretty much ready to go. This being a small cell lung cancer, barring any contraindications, you want to do chemotherapy, platinum-based chemotherapy with immunotherapy, either durvalumab or atezolizumab. I'd probably want to talk to the neurologist here and find out how the Parkinson's is and if there's anything we need to be careful of, but I doubt that that would preclude anything. And I'd try to start one of these regimens within a couple of weeks, even sooner. Of course, you need to have shared time at many of our centers, but this is the type of thing that needs to be prioritized. Uh, Initial treatment for extensive small cell, which this is now that it's outside of the chest, needs to be treated quickly.
Matt, anything to add here? Any potential barriers you see for patients who are newly diagnosed with small cell lung cancer?
I think a lot of the biggest barriers that newly diagnosed patients run into is if they are deciding that they want to continue their care at that center where they were diagnosed versus if they want to try to step to a different center. There's always that delay of information being transferred between centers. I think that what makes it most efficient for patients is being able to understand what's available at their current treatment center. Standard of care stuff, I think, usually goes relatively straightforward. And I agree that patients are very interested in getting onto treatment as quickly as possible. I think many of them, once they start reading about small cell lung cancer, understand it to be an aggressive disease and really want that treatment. However, if there are individuals who are interested, for example, in clinical trials, depending on where they are, that might be a step that requires them going somewhere else. And there's a little bit of a delay there, as well as the onboarding and screening process itself for a clinical trial, especially at first line therapy. So if it's appropriate for the patient, that single and other thing, I think it can really potentially delay treatment, which is why ultimately I think a lot of patients, especially in the first line setting, tend to go standard of care. Although I think it's always worth having the conversation at least so that the patient understands all of their treatment options, even if the correct option for many patients is going to be that standard of care.
I think, it is also helpful if we have navigation in our systems to really help patients on that onboarding process. Our systems, our medical systems can be quite daunting for patients to navigate, and to have a friendly face that can welcome them in and help guide them through the steps until they get to see their oncologist, I think is really helpful too. That leads me to my next question of coordinating with a multidisciplinary fashion and with other specialties, other ancillary support, social work, dietitians or nutritionists, palliative care. Matt, will you speak to kind of the role of additional support for patients with small cell lung cancer?
Absolutely. I think that having a multidisciplinary approach really just brings the best possible care to the patients themselves. Obviously, as oncologists, you guys know the best about treatments and what to look for, what the side effects or profiles are going to be. But especially when it comes to palliative care services, starting that early and having the patient understand that there is a difference between palliative care and hospice care, because I think that's what many of them think of in their mind when you say palliative care, really leads to people having better quality of life while they're on treatment, which is really what I, in my experience, have heard a lot of patients really prioritize. Is I think many of them can come to accept what the diagnosis is and what it means for their futures. But most of them, what they're really interested in is what is the time I have going to look like? Can it be meaningful? And introducing earlier other specialties, they're able to help manage those things so that they have a higher quality of life long term, I think leads to better outcomes for patients overall.
Absolutely. Thank you so much. Roy, anything to add here on the role of multidisciplinary care for patients with small cell?
Well, if this was a more limited situation, we'd of course work very closely with radiation oncologists. You'll still need radiation oncology for areas of symptomatic persistence or recurrence. Um, but at this point, this really is in the hands of medical oncology working closely with palliative care as well.
And then finally, here, are there additional tools, resources, and support for patients with small cell lung cancer? Matt, I'll ask you first.
Yeah, so that I think there's a lot of stuff that people can connect with online in different mediums. Go to for lung cancer, for example, is a organization that has a lot of different offerings. We do everything from approachable educational materials that are really able to break down the complexity of disease so that it's easy for them to understand. There are support programs that we sponsor around being able to talk directly to other individuals going through a similar diagnosis. There are community-based meetups that individuals who want to kind of like be in a more of a support group setting can find, and that's just within GoTo. There are also excellent patient programs that exist outside GoTo, such as the Small Cell Smashers. There's a really great community program for individuals with small cell specifically. That I think anytime that you can find more people who have been through similar diagnosis, you have a better chance of really being able to feel like you are included as part of the community. I feel like I know a lot of information I can kind of communicate to them, but I myself am not a patient. So I think it comes differently when you hear the same information coming through a person who has taken the same treatment and has been through the same hardships. I think it ends up making them feel like they're not really truly in this alone.
Thank you for that. And absolutely, no patient with small cell or any loved one or care partner should ever feel like they are going through this journey alone. So, with this patient, to give some updates, she did meet with her neurologist and was cleared to do chemo immunotherapy. She actually did very well with that regimen. And then unfortunately did have a platinum resistant relapse of her disease, is now on tarlatamab with no evidence of disease and doing significantly better and doing well and really thriving and smashing her small cell. And so, with that, concluding this case, any additional remarks that we may have not touched on here, Matt?
No, I think that it's great to hear that she responded well on second line treatment. I know there's a lot of excitement coming down the pipeline for new treatments that are being developed, especially in small cells. So exciting to hear that she's doing well on one of the newer ones, and hopefully that she is able to continue for quite a while. And then maybe there's something new and exciting right behind that if she ever needs it.
Thank you so much. Roy, anything additional to add on this case?
No, I think, this patient hopefully goes full speed ahead with some of the therapies. We manage toxicities delicately, uh, gets good support, from the community, and we hope for a good outcome and to extend her life, as long as possible with good quality.
So I think our key takeaways here for this case are that patients with small cell lung cancer should have expedited or urgent workup. We should get them plugged in with a medical oncologist and a multidisciplinary care team. We really want to help support them as much as possible with early palliative care, diagnosis, and implementation of advocacy groups. As mentioned, there are so many, and there's so much support for patients with small cell, and outcomes are really improving. And really, hope is here, I think, to stay for this challenging disease. Again, thank you, Dr. Roy Herbst and Dr. Matt Rice, for your expert insight into this panel. And thank you for your attention to this case discussion. And we hope you stay tuned to the next case. Thank you.
Welcome back. I'm Dr. Tiziana Leal. I'm professor and director of the Thoracic Oncology program at the Winship Cancer Institute of Emory University in Atlanta, Georgia. Today, I'm joined by Dr. Misty Shields and Matt Reese, whom you met in the previous segment. We'll be discussing another patient case, selecting treatment through shared decision making. So let's start with a case from my own clinical practice. This is a 53-year-old male, former smoker, who presented with worsening right shoulder pain for 6 months. He complained of a frozen shoulder, but upon further review, he also had developed additional symptoms, including intermittent shortness of breath and cough. He developed an episode of feeling pressure in his chest when he was snorkeling while on vacation. Review of systems was also positive for muscle cramps that he attributed to statins and right hip pain that had developed over the past 6 weeks that he had managed with acetaminophen. Past medical history included diabetes, coronary artery disease, and hyperlipidemia. On initial workup, the patient did undergo a CT scan of the chest, angio to rule out pulmonary embolism, and it showed a large right hilar mass with partial encasement of the right main pulmonary artery and right pulmonary vein, as well as enlarged mediastinal lymphadenopathy. He subsequently underwent an outpatient bronchoscopy with mediastinal staging, which demonstrated presence of malignancy, with the right middle lobe being positive for small cell lung cancer, as well as lymph nodes in the chest, including the mediastinal lymph nodes, as well as the right hilar lymph nodes. The brain MRI was negative for brain metastasis at baseline, and then additionally, he underwent a PET CT scan, which unfortunately demonstrated evidence of additional disease beyond the chest. As you can see here in the first to the left, we see a screenshot of his large right hilar mass that's extending into the right suprahilar region and also the right upper lobe, kind of invading into the mediastinum and also leading to post-obstructive pneumonia. Additionally, he had several FDG avid lymph nodes that I'm not showing here in the right hilum as well as mediastinum. He also had a liver metastasis, as is shown in this slide in the middle, as well as multiple bone lesions, including a bone lesion in the right hip, but did not have right shoulder involvement. So let's talk about next steps in the treatment for this patient with now newly diagnosed extensive stage small cell lung cancer. I'll add to say that his performance status, despite the right hip pain, was actually excellent, and he had a PS of 0 and adequate organ function as well, including a normal CBC, normal liver and hepatic functions. So, what are the treatment options for this patient in the first line setting, and what is the urgency to start treatment for this patient? Ms. TL, I'll give you over, what your thoughts would be for this patient case.
Thank you, Tishiana. And, with this patient, we always promote urgency with the diagnosis of small cell lung cancer. We have a pathologic diagnosis of small cell. We have completed staging, as you mentioned, with a brain MRI, CT chest and pelvis. And so typically with patients with small cell lung cancer, we like to get started on treatment within a few days to a week of the diagnosis. As we know with small cell, that there's a high proliferative rate and that there's a quick doubling time of this tumor. Of course, as we all know, we always are looking for clinical trials. And so, first checking to make sure that this patient is not eligible for any clinical trials that we can get the patient plugged into. In the absence of a clinical trial here, I would start this patient on chemoimmunotherapy, as we saw with Empower 133 and the Caspian studies shown that were FDA approved in 2019 and 2020 for this patient.
Excellent. Matt, from your perspective, any additional thoughts that you would add in terms of shared decision making and then thinking about support networks for this patient?
Yeah, no, I agree for the most part, exactly with what Dr. Shields laid out there. Patients are really anxious, especially after a small cell diagnosis, to try to get on treatment quickly. And I think that having the established treatments ready to go is really good to be able to communicate with the patient what those treatments are, what the outcomes expected are, and what side effects they expect are.
Yeah, for sure. And I think that's really critical. And in the case of this patient, also involving his significant other and caregiver who was also involved in making sure that she also understood and could be involved in this shared decision making process because that's what he also wanted. So we talked about, Misty, you mentioned the two standard regimens that we use in first line induction with the option of maintenance as well, with chemoimmunotherapy as our standard of care based on the Empower 133, which combined chemoimmunotherapy with platinum etoposide and atezolizumab, and the Caspian regimen, which involved the use of chemoimmunotherapy with durvalumab maintenance. Both of these regimens have led to improved outcomes, including improved overall survival with good tolerability of these regimens in the frontline setting. And then it includes a first line maintenance option with both regimens with atezo every 3 weeks and durvalumab every 4 weeks. And these regimens are continued until progression, as long as the patient is doing well, tolerating treatment, and wants to keep going with the regimen. We also now have the approval of the Inforte regimen, which is the addition now in first-line maintenance of lurbinectedin, which is an agent that is a transcription inhibitor after induction therapy that led to improved overall survival and recent FDA approval. And then most recently, we've had really promising results in first-line maintenance with the addition of tarlatamab in first-line maintenance, and now with the Delphi 303 trial, this not yet approved, but certainly showing very promising data. Now that we have other options for first-line maintenance, I briefly address it while we're talking about induction, but certainly importantly to break down that information and then kind of bring up different options for first-line maintenance. Let's talk about the first-line maintenance trials that we currently have some data about, including the Inforte regimen, which led to the approval of lurbinectedin in first-line maintenance. The Inforte regimen included patients who had completed induction with atezolizumab plus carboplatin and etoposide, followed now by randomization to first-line maintenance with lurbinectedin plus atezolizumab versus atezolizumab. This trial met the endpoints of progression-free survival as well as overall survival, including improved response rate during the maintenance phase compared to atezolizumab alone. And I think importantly, as we think about this regimen, the randomization is after induction. So here, this median overall survival that we're seeing of 13.2 months also needs to take into account the improved outcomes that we saw with induction. So it's 13.2 months plus the addition of induction. We have an overall survival of over 16 months, which I think it's the best survival that we've seen in the setting of chemoimmunotherapy followed by first-line maintenance. We also have the Delphi study, which added now not only the immunotherapy component in maintenance, plus also adding tarlatamab, a T-cell engager, in combination with anti-PD-L1 therapy. And here in this early phase study, again, we're seeing very promising outcomes, including median duration response of 11 months, as well as a very sort of exciting median overall survival of 25 months in an early phase trial. But now we're waiting for the results of the randomized phase 3 trial, combining durvalumab plus tarlatamab in first-line maintenance.
I think that this data shows that there is an opportunity to improve outcomes for patients with small cell lung cancer who undergo chemoimmunotherapy. Far too many patients never reach second line therapy. So, if there's an opportunity where we've maximally debulked the disease with induction chemoimmunotherapy to add it on and really drive home good outcomes for our patients, this is what we want to do. This is what patients want: is more time and more quality of life. I think the Delphi 303 is a very exciting early phase trial, and the Delphi 305 is the confirmatory phase 3 study and ongoing. I think we're going to see really exciting data and potentially shift the landscape as we know it with tarlatamab in the first line setting in the maintenance phase.
Excellent, Matt. And I just want to bring it to you in terms of, getting the patient perspective in terms of adding additional therapies in first-line maintenance.
I think that patients, for the most part, certainly understand that if they're given an additional drug, there's likely going to be some extra side effects that come with that. I think that what really makes it meaningful for them is understanding the added benefit that comes from that additional treatment. I know that for both the Inforte and the Delphi studies, the outcomes are really exciting. And especially as you get to the maintenance setting, this is where patients are starting to learn a little bit more. So they actually might know the name of some of these drugs at this point and how much it has improved from the standard treatment that came before. So for a lot of patients, as long as they understand what to expect, and maybe how that is being managed, it kind of becomes a trade-off for them.
Yeah, and I definitely think we can continue to work together to optimize and manage these side effects. So I think this is where working with palliative care can also be helpful. And again, if dose modifications are needed, I think this regimen is one that also allows for us to dose modify if needed to continue to allow patients to benefit from the regimen and manage the side effects with lurbinectedin plus atezolizumab. So let's talk about, how do you select first line maintenance? And I think two really important questions. In the case of our patient, he does not have any baseline brain metastasis, but would your choice of first line maintenance be different if he did have baseline brain metastasis? And then the second question is, lurbinectedin was previously approved also in an accelerated fashion in second line and beyond. And now we're moving lurbinectedin earlier here in first line maintenance. So does this change what treatment options you have overall for this patient, and does it change your decision what you choose upon progression? So, Misty, I'll give you those two questions in sequence, and then Matt, give me your perspective from a patient in terms of, the brain and how to view that.
Yes, absolutely. The presence of brain metastases at baseline would change my management of this patient. I think that that would be a patient I would be discussing chemoimmunotherapy followed by immunotherapy maintenance and close monitoring for any early signs of progression with the imaging of the brain and the body with MRI brain and CT chest and pelvis at close intervals. I think with a patient who is going to receive Forte for your second question, and as the maintenance strategy, and if there was evidence of progression on restaging scans, that's a patient that I would talk to about the role of tarlatamab in the second line setting. We saw the Delphi 304 demonstrating a significant improvement in overall survival over topotecan, amrubicin, and really kind of underpowered to look at lurbinectedin there, but potentially a signal there. So that would be my next line of strategy for patients.
Excellent. So let's move on to our patient. So our patient did start induction therapy with chemotherapy with carboplatin etoposide and atezolizumab with the Empower regimen. He actually tolerated the treatment quite well. No complications, no hospitalizations, no ER visits. But here are scans at baseline. As you can see here at baseline, he has a large mass in the right lung, sort of invading into the mediastinum, causing post-obstructive changes as you see there. And disappointingly, after 4 cycles, you see some shrinkage, but I was really hoping for more tumor shrinkage. Any comments there, Misty? Do you see this, or is this concerning to you?
Absolutely. We do see stable disease after this intensive regimen of chemoimmunotherapy induction. These are patients I do worry about going on immunotherapy only, that the disease may relapse and relapse early. There's a large amount of tumor still there. We don't know if all of it is viable with just a CT scan alone, but you have to be very much concerned and worried that this patient is going to have recurrence because of the amount of disease that still remains.
Yeah, so here's some additional sort of information about him. The right hip pain did improve, which we knew was related to cancer, but he still required pain medications even at cycle 4. Here's the follow-up scans. To the left are the follow-up in the liver, and then what we're seeing here is some decrease in the disease in the liver as well, some representative lesions that we're seeing here. He has stable disease. He had a 15% decrease, mainly related to the liver lesions, but overall, here is stable disease per RECIST. What are the next steps for this patient, and what is the best choice for first-line maintenance for our patient?
Yeah, so I think in this scenario, these scans are sometimes met with a little bit of disappointment from patients and their care partners. Um, they feel that they've put in 3 months and had chemoimmunotherapy, and they're sort of disappointed that there's cancer still remaining. I usually remind patients that, again, remember, this is a disease that likes to grow and spread. And so that is also a victory that there's no growth and there's no spreading, there's no new lesions. And so I think, discussing the results, framing and reframing the findings, and then also, again, I think that having a shared informed decision making of we could consider immunotherapy or the addition of lurbinectedin to this maintenance phase would be what I'd offer patients. And, I really would be encouraging the addition of lurbinectedin here because it was a stable disease and not a partial response, excellent partial response, or complete response.
Yeah, I agree that stable disease is sometimes not always viewed as positively as we would hope for patients. So I think it is important to approach it with a positive framing of how it is not growing, and therefore this is a positive step. I also think it's important to make sure that they have clear expectations of how that might change over time. For some individuals, maybe it becomes a lifestyle of stable disease and treatment, and what that is going to look like for them as an individual. For other individuals, they should know that there is going to be that continued monitoring, but that it is a possibility that at some point this may continue to progress, but that there is options afterwards that we are prepared for, and that discussion will take place at that time. I think that as long as the patients are prepared that there is a potential for change in the future, they can kind of mentally set themselves up to go into a maintenance setting with stable disease in a positive fashion.
Yeah, excellent. Thanks for all that insight. And I think just to kind of summarize for our patients specifically, I think thinking about what to do next and how to continue to sort of improve on this outcome. As you know, the Inforte regimen was recently approved, so we're just now really rolling this out in clinical practice. And we've talked about first line maintenance strategies, including a repeat brain MRI. And repeat brain MRI was negative, so no evidence of brain metastasis. And I think looking at the subset analysis of Inforte, I think it was meaningful to me to see that patients with stable disease derived that benefit from lurbinectedin. So that's the strategy that we're taking for this patient, undergoing first-line maintenance with lurbinectedin and atezolizumab, and then continuing to monitor for side effects, optimizing those, and then sort of making sure that we're monitoring the brain with brain surveillance as outlined earlier by Misty. So once again, I just want to thank you all for just being here with me today. Misty and Matt, thank you for this great discussion. And thank you for participating in this activity. Please continue to the next chapter for a discussion on addressing potential toxicities and prioritizing quality of life.
Welcome back. I'm Roy Herbst, and I'm joined now by Tiziana Leal and Matt Rice to discuss our last case, addressing potential toxicities and prioritizing quality of life. We have a case, a 64-year-old man with extensive stage small cell lung cancer, with metastases to the liver and the bones. After 4 cycles of carboplatin and etoposide with atezolizumab, he achieved a partial response. This patient then started maintenance therapy with atezolizumab and lurbinectin, per the recent data presented at ASCO in 2025. He had his 3rd cycle of maintenance therapy 2 days ago. 48 hours after receiving the lurbinectin infusion, he calls clinic with a fever of 101.2, malaise, and a mild right upper quadrant discomfort. At arrival in the emergency room, the labs showed a CBC with a white count of 1.1 with an ANC of 0.32. So this patient has grade 4 neutropenia. The hemoglobin is 10.5. The platelet count is 140. Looking at some of the other labs, the AST is up at 165, the ALT at 190, both about 6 to 8 times the upper limit of normal for that lab. Total bili is pretty much normal at 1.0. The chest x-ray shows no focal consolidation. Patient does not have any cough or dyspnea. There are no prior hepatitis serology values or changes. So let's have a little discussion about this. Tiziana, what do you probably see this from time to time, patients with who are on this type of drug and either lurbinectin or other drugs. Let's start with the lurbinectin. What do you do here? Do you hold drug? How do you manage the neutropenia?
Yeah, I think, one thing that I was wondering about at baseline, were the LFTs normal? The other thing that I'm also wondering about that I didn't see in the initial description of the case was whether this patient received growth factor with the maintenance therapy. Because in the Inforte trial, patients received prophylactic growth factor, and this could have potentially prevented this patient from having grade 4 neutropenia, in the case here, neutropenic fever. So I think, first of all, it's really important that patients receive prophylactic growth factor from the get-go. We certainly have to provide supportive care, growth factor in the hospital, blood cultures, full workup for source of infection, imaging, urine cultures, and so on, and then starting broad spectrum antibiotics for management and treatment promptly of neutropenic fever. With regards to the LFTs, again, I actually haven't had LFTs go up like that quickly after treatment, but certainly the patient is receiving lurbinectedin and atezolizumab. I think it's important to differentiate whether this is chemotherapy toxicity from lurbinectedin, whether this is due to sepsis and infection, and then third, you want to make sure this is not immune mediated. So certainly having a full workup to try to understand that, including imaging, because this patient does have liver mets at baseline, to try to make sure that this is not due to progressive disease. So it does require this differential diagnosis and perhaps in the hospital here, multidisciplinary care in case we need additional input from other specialists.
Well, let's move back to and talk a little bit about lurbinectedin. And because what I'm wondering is, can we be more proactive in our monitoring, early intervention, coordination with specialists?
Yeah, I think, overall, the Inforte regimen with the combination of lurbinectedin plus atezolizumab was actually a well-tolerated strategy. Certainly, there were more adverse events when you compare it to atezolizumab monotherapy, but in terms of treatment discontinuation of the regimen, that was actually quite low. It was in the order of 6% with lurbinectedin plus atezolizumab. And overall, you saw a higher exposure of therapy with the lurbinectedin and atezolizumab, where we saw, from patients being on treatment longer, you would expect that perhaps they would have these side effects. But beyond the ones that you mentioned, nausea, fatigue, decreased appetite can also be side effects, as well as other GI side effects like diarrhea or vomiting. And with dose modifications, again, in supportive care, we can get patients through the treatment safely and keep patients on therapy if they're benefiting from it and want to stay on.
All right, thanks. That's a very complete answer. It's an interesting time. We have many more choices of drugs, but we're combining therapies. So we do need to be very mindful of the toxicities and the patients' of quality of life, especially here where, this is still probably not a fully curable situation. So Matthew, from your perspective, patient quality of life and what's been your experience with lurbinectedin and other drugs like this?
Whether it's lurbinectedin, tarlatamab, any of the treatments we're talking about, it's pretty consistent that for the side effects for patients, most of the time they're not thinking about them when they first start treatment. They're interested in what the treatment is and how it's going to benefit them. So I do think it falls on you guys as the oncologist to make sure that you're clearly communicating what are the things they need to be looking out for and how these things might be able to be managed. And Tiziana, we brought in the idea of bringing in a multidisciplinary team to manage the side effects as they become present.
Now, on everyone's mind these days is tarlatamab. What if the patient had received that? Perhaps on an earlier clinical trial. What AEs are most common with that?
Yeah, so tarlatamab is a T-cell engager targeting DLL3, which we know is highly expressed in small cell lung cancer. It is now approved in second line and beyond. Based on randomized phase 3 data showing improved overall survival. But in this case here, let's say the patient was on a clinical trial receiving tarlatamab in first-line maintenance. The most common side effect of tarlatamab is cytokine release syndrome. It does happen most commonly in the first or second cycles, so it does require close monitoring and 22 to 24-hour observation for cycle 1, day 1, cycle 1, day 8. You're also doing, up titration. You start at 1 milligram for the first dose, 10 milligram and beyond for the second dose and on. But in terms of monitoring, importantly, the majority of the CRS that does occur is grade 1 or 2 in nature. But if patients do develop CRS, the most common presenting symptom is fever. So again, making sure that you rule out infection or other causes of fever. If it's fever alone, you have to grade the CRS, again, grade 1 or 2, most common. But it's important because, if patients start to escalate to grade 2, now they are continuing to have issues with perhaps blood pressure, they may need IV fluids, dexamethasone, and that requires perhaps prolongation of that observation period. Most of the patients are managed with supportive care. IV fluids, dexamethasone, acetaminophen, and if needed, antiemetics to kind of get them through the CRS. And then again, here, multidisciplinary care is critical. I think it's very important to educate everybody on recognition of CRS, not only in the infusion clinic, the inpatient team, the ER, in case these patients are going home and they need to come back in because they are developing CRS.
Thanks. It's an active drug, but it certainly warms up the entire immune response. So Matthew, what's your perspective? What are patients thinking about this going in? What sort of education is there? What are the supportive care options to help patients through this?
I think that just given how well known of a side effect has become with this new treatment, I actually have been surprised how many patients are aware that there is that potential serious side effect. And they tend to ask a lot of questions about it. when we connect with them. So I think that the best thing that can be done is obviously oncologists making sure that they educate the patient, as she outlined, about like the side effect may look like, how to identify it early, and when it's necessary to come in and have it addressed. I think that overall, it is proportionally a smaller amount of individuals. It is proportionally towards the beginning of treatment and tends to go away after the first or second cycle. I think that for a lot of patients, understanding basically what they're looking for, and that for a lot of them, that risk of the side effect going away over time is usually outweighed by the benefit of the drug itself. So a lot of them are very embracing of trying the treatment itself.
Yeah, I was just going to say, Matt, that's a really good point because sometimes patients have CRS for cycle 1, day 1. And so they come back and they're like, wow, do I really want to get cycle 1, day 8? And it's kind of coaching them and explaining that the CRS could happen again, but that we can support them through it. And once we get through cycle 1, day 8, the rates of CRS are significantly lower and patients can do really well, especially when they achieve a response, which the responses actually happen fast. So, getting through those 2 doses, supporting patients and coaching them through it is a really important piece of, making sure that patients are okay and understand what they're facing to get through the first 2 doses of tarlatamab if they have CRS.
And I'll say that temporal factor is really key for a lot of patients in that decision making process, because I think that if they go in with the assumption like this is an ongoing risk that I'm going to have to potentially watch for the entire treatment cycle, however long that goes for, I think they're a lot more hesitant than what they know that it's only like, oh, it's only really the first 2 times that I'm gonna have to really pay that close of attention to these things. I feel like patients are much more comfortable with taking that risk and getting the derived benefit from the drug itself.
Okay, excellent. So these are discussions that have to occur. What resources are available to the patient to be proactive, to understand how to manage toxicities, to work with their caregiver, Matthew?
We'd probably start by just pointing the patients to online support organizations such as GoTo, Longevity. There's many, many lung organizations. And I think a lot of them have taken a lot of time to make sure that we're curating a library of educational resources that are written in plain language for patients to be able to understand the diagnosis and what the treatments are and how they're expected to work. And then I know that we put a lot of effort also in our materials to make sure that, it's not to replace what you guys are doing, but to supplement the conversation outside of your office visits where, I know for a lot of patients, this is, very scary. There's a lot of things that are changing. A new treatment introduces new questions. So having resources available, at least as a starting point, but then also being able to then connect with other patients who have been going through similar treatments, it allows them to be able to kind of bounce their questions and ideas off of other individuals who have gone through similar treatment prior to coming back to the office to you guys, so that they feel more empowered to participate in that conversation and really express the parts that are most concerning to them so that they end up with better long-term outcomes.
Right. This has been a great discussion. It really puts into perspective the need to work as a team, include your palliative care specialists, advocacy organizations, have a strong communication in a bidirectional way, and then always reassess the treatment goals. And I would like to thank both of you for your time. And with that, we'll end this case. Thank you all very much.